Okay. All right. Let's start with Ed, since he gave 2 talks. What impact does a somatostatin analog like lanreotide have on getting a gallium-68 scan? And if you get a shot close to when your scan happens, is it going to influence the result?
That's a terrific question. Actually, you need unbound somatostatin receptors to have a gallium scan, just like you do to have an arterial scan. In real life, most people have such strong binding of somatostatin receptors that even if you do the scan at the wrong time, it will still turn out to be positive if you have receptors. But if you want to get a really good scan, it's better to wait until close to when you're due for a octreotide, LAR, or lanreotide injection, and then do your scan. So in other words, if you wait for 3 or 4 weeks, I think you'll get a better scan. If you have to delay your injection by a couple of days, that's okay too. Just do the scan first and then get your injection. But it's better to do it at a time when you're not loaded with somatostatin analogs.
Okay, thanks, Ed. Joe, regarding Zermela, one question that came up is the product sheet shows that bowel movements were reduced by only 1 bowel movement over placebo. And this person is saying that, well, it doesn't sound like very much reduction. So is that really what we can expect from Zermela?
Yeah, I think the average number of bowel movements that people started with was around 6, if I remember, and it goes down by 2, but it also changes the consistency of the bowel movements and the urgency. And if you look at the satisfaction data that patients have with it, patients in whom it does work are very satisfied with the result. Is there more that can be done? Sure. Serotonin, I think, is only part of the cause of diarrhea. There may be other hormones that cause it. There may be other causes of diarrhea, as I outlined, but it does. It's used in people who have significant diarrhea, even on higher doses of somatostatin analogues. So it's I think it's a significant step forward, and it is more than just that number of actual number of bowel movements. There's the issue of how loose the bowel movements are and how urgent they are.
Joe, does it help with flushing?
Just a real quick. Yeah, just real quick. There's also unexpected. We saw weight gain with it as well.
Yes. Does it help with flushing?
I don't think it significantly helps with flushing. There are some people who I have on it, and some people in the studies, in some of the earlier studies, where there was a significant decrease noted in flushing. So I wouldn't. I don't consider it for my patients who have flushing as their primary issue without having diarrhea.
Okay, Lowell, here's one for you. Do any of the new immunotherapy drugs seem useful in treating neuroendocrine tumors?
So the immunotherapy drugs the approach we have right now, we're going to have to say no, particularly if it relates to the grade 1. So the reason for grade 1 is there's not very many mutations, and I guess that's a good thing, but it's a bad thing for immunotherapy. We know when there's a high mutation burden, and we see this particularly in lung cancer where there's been a high carcinogen exposure. Those are the patients that benefit. So I don't want anybody in here to start smoking if you have grade 1 so you get lung cancer so your immunotherapy will work against your carcinoid. That doesn't make sense. But what we're trying to do in the world of immunotherapy is we're trying to make cold tumors hot to the immune system. And that's where, just because it's not active today doesn't mean it won't be active at some time in the future. But for the grade 2 and the poorly differentiated, your grade 3 is where it looks like it may have. We've seen responses there. So I think there's hope, there's promise, but it's going to take time to figure it out.
Okay, David, here's one for you. first, this is about IRE. How widely available is this technology for liver and other tumors? And second, why wouldn't you use IRE in every instance of liver mets, given its more precise nature than microwave ablation?
Sure, thank you for the question. So IRE is not really commonly available in the United States for several reasons. One, the device is very expensive, around $400,000 just for the generator. And technically to do it is difficult to do it well. So most surgeons and physicians don't have the expertise to use it. If you compare, so that's the primary reason that it's not commonly available. Now, again, we're working on making it better, upgrading the software, the second generation's coming out, we're building a different device the outputs will be a lot easier. So our job is to try to make it easier for users. When it comes to why do we do microwave versus IRE, it's purely practical. If you can ablate a 2-centimeter lesion in 2 minutes versus 10 minutes with IRE or 20 minutes or 30 minutes, it's just much more practical to use microwave. And if you're good at microwave, you can do parenchymal sparing techniques. So again, I would say that for liver metastases, 90+% can be handled with microwave, and in specific circumstances against major vascular pedicles, someone reminded me, if you've had a Whipple or a biliary bypass where you have chronic cholangitis, those would be the situations where IRE are more useful.
Great. All right, Ed, for you. The speaker yesterday indicated that a negative gallium scan means the disease has progressed to high grade. Is this true, or do some neuroendocrine tumors simply lack receptors? And follow-up of that question, if you're negative on the gallium scan, is PRRT off the table?
It's not true that you're high grade if the gallium scan is negative. In well-differentiated neuroendocrine tumors of the gut, probably 90% are positive on gallium scan, something in that neighborhood. So, but there still are 10% that are negative, and that does not make them high grade. It just makes them not have somatostatin receptors. In the case of pancreatic neuroendocrine tumors, the percentage is higher than that of people that are going to be perfectly negative, even though it's a well-differentiated tumor. In lung, it's even lower than that, but it's either positive or it's negative in any individual person. If it's negative, it completely eliminates the option of PRRT with lutetium-177 dotatate, since it requires exactly the same binding. There may be some new molecular targets, as I mentioned, that aren't going to involve the somatostatin receptor, but that's different than our normal use of PRRT.
Okay. Joe, a two-pronged question for you. Is there a link between carcinoid syndrome and tumor progression? And second, sort of related to this, is what's the best way to diagnose carcinoid heart disease?
Let me take the second one. Come to Heidi Connolly's talk in about an hour or two. In my mind, the echocardiogram is very important in diagnosing the carcinoid heart disease. And then the first question was progression of carcinoid tumor and the presence of carcinoid syndrome. It's a really interesting question, and it relates, and there is sort of ongoing research on this, and it does indeed relate to the medications like telotrestat, and there's a question of whether serotonin itself might be a hormone that enhances tumor growth. I don't think there is some data to suggest that serotonin in some tumors might enhance their growth, but I do not think that's well worked out. Don't know if you have any other comments on that.
So I think anybody that has stable disease on their scans and worsening syndrome, particularly if their 5-HI is going up, then you have to sort of think about maybe it's an early indicator of progression. We all know that the 5 E's that Dr. Dillon talked about is clearly could be flaring the symptoms despite the disease being stable on the scan. So I think we're all real sensitive when the syndrome is getting out of proportion to what we see on the scans.
Okay, Lowell, I want to ask you some questions about capecitabine temozolomide. First, so I got three of them. First, under what circumstances should it be the first approach to PNET for the treatment? How do you deal with low platelets? And then an individual who is on CAPTEM said he's now off somatostatin analogues and is wondering whether there's any benefit to being on both.
So when do you start CAPTEM? A great question. You might say if it was grade 2 and there was a reasonable bulk, it would be a no-brainer. What we want to do is sort of push the edge a bit with it. We know we have a form of therapy that we can cytoreduce tumors. Unfortunately, we cytoreduce metastatic disease greater than we reduce the primary disease. In Dr. Strasberg's study, it's not real well defined in his report, but asking him face-to-face, 1 out of 5 or 20% of the primary tumor shrank, whereas in his case of 30, 70% of liver metastasis shrank. So that's a pretty big differential, and the reason is that these primary tumors have a fibrous skeleton, and we don't really see these tumors shrink with almost any form of treatment. We don't see them shrink with PRRT, and so in 1 out of 5 we do. So in some patients that we may want locally advanced, we might want to use it for 3 months up front before surgery, and allow the person to see if it could be a better operative outcome if we can shrink the primary. That's one approach, certainly not standard. But I think that patient who's symptomatic, who has high bulk disease, who has grade 2 disease, pancreatic primary, is a no-brainer. When you start looking at lung primaries, and you start looking at small bowel primaries, that takes a little bit more understanding of the things. The second one is
Platelets.
Platelets. So platelets is an expected reduction from the temozolomide, not the capecitabine. In most cases, there is an enzyme that metabolizes 5-FU that could do it, but most people have plenty of the dihydropyrimidine dehydrogenase enzyme, or 5-DPD. But the temozolomide is an alkylating agent. What does that mean? It means that the drug binds to the DNA in the stem cells, the megakaryocytes responsible for creating platelets. So it takes time to recover. So eventually, if you took the temozolomide for years and years and years, your megakaryocytes at some point will get fatigued, and they just won't be able to produce adequate number of platelets. So what it means is there needs to be either a dose reduction or a delay, some alteration. And then the last one is about somatostatin analogues and CAPTEM. So we have to really look at what the somatostatin analogues do. They improve quality of life, they delay progression. And if any time another form of treatment is doing that same thing, then we can put into question how valuable somatostatin analogues. Historically, we've used the two together, but it's not uncommon now that we've got more active treatment, then we could not necessarily continue this combination. So it would make sense to at least give a trial without the somatostatin analogues and see if they were really doing anything to either quality of life or eventually the tumor itself.
And just one more comment on the use of somatostatin analogues when they're no longer controlling the cancer. It's a really, really important and unanswered question in neuroendocrine oncology about whether we should continue those drugs. There's a big school of thought that you should continue somatostatin analogues for life, even if they don't work, because if you stop, the tumor might grow faster in a population of people who have strong somatostatin receptors. And people think about it like prostate cancer that doesn't respond to anti-androgen medications anymore and is starting to grow and people are on chemotherapy. Normally, you don't let testosterone go up to normal in somebody with metastatic prostate cancer because you're afraid the cancer will grow even faster. So even though it's not working very well, you stay on the anti-androgen and you add chemotherapy to it. People are feeling that way about using somatostatin analogues in treating neuroendocrine cancer, but there are no formal studies that you could point to saying this is the standard of care, you have to continue doing it. And it's largely a matter of belief rather than science. And I think you have to make individual decisions. If people have trouble tolerating a somatostatin analog when it's not working anymore, I wouldn't push for it. But on the other hand, if you're doing well and you're on a somatostatin analog, I think many people would continue it and just use another treatment on top of it.
Okay, Dave, this is a question for you. These have to do with indications for liver surgery for neuroendocrine tumors. So the first question is, if you have more than 10 tumors in the liver, but it's not otherwise anywhere else, what decision tree do you use to go with surgery? Do you have to wait until symptoms occur, or would that be too late? And then second, if you have a grade 2 tumor, should you have surgery or should you have systemic therapy?
So good, challenging questions, I would say. Number one, when it comes to number, that's not really important to us. Again, when we're talking about neuroendocrine, we're talking about liver-directed therapy, we're talking about a systemic disease. And so again, when we get to the point of liver surgery, that truly has to be taken into the context of the overall treatment plan. There are a few easy answers, I can say. So certainly if somebody has refractory symptoms from an somatostatin analog and they have symptoms, then a debulking procedure is certainly associated with improving their symptoms. So that's certainly an easy one. 10 liver mets could be 10 liver mets isolated in one lobe of the liver versus the other. So that's certainly easy. 10 liver mets distributed in both lobes of the liver. Again, it's location, size, volume, all of those things that will affect our decision making. So it's not a straightforward answer, and it just has to be taken into the context of the disease. Obviously, if one is growing or several of them are growing, they're becoming more vascular, there's something pushing us towards the direction of surgery, again, that would be the way I would answer that question. What was the second part of the question? Grade 2. Yeah, so that gets a little, high KI index. That's kind of a little bit of a different disease. And again, we would probably lean, again, so many variations out there, we would probably lean on some systemic level therapy first, most likely chemotherapy. Demonstrate a period of stability of disease. If we have demonstrated a period of stability of disease, then we would consider a local regional therapy, surgical resection, ablation, or what have you. Again, case-by-case scenario. I do want to make a comment, by the way, about, since I've got 3 medical oncologists up here, and one of the co-authors of New England. Oh, endocrine? That's all right. We won't hold that against them, right? About response rates. So when you're looking at PRRT response rates, particularly in the New England paper, and you look at response rates, they seem to be overall low. I don't think that actually correlates to true response rates because, again, this is technical more for these guys. They use something called the RECIST criteria. And so everybody wants the tumor to shrink, right? But as he was mentioning that there is a lot of fibrotic stroma within these tumors, and whether it's chemotherapy, antibody therapy, radiation therapy, what have you, sometimes the tumors just don't shrink. That's okay. Surgically, we don't care, to be honest with you, and usually the common thought out there is that you have to shrink a tumor, so you make an unresectable tumor resectable. That's pretty much not true in the surgical world. Everything we do in surgery is based on vascularity, tumor relative to vascular structures. That's what we live off of. So so if you get to tumor shrinkage and a positive RECIST or a 30% shrinkage, that's such a small percentage of patients. And again, it doesn't correlate to true response. So there's another criteria. So I'm going to challenge these guys as they publish their papers to use something called a modified RECIST criteria, which is actually the change in the vascularity of the tumor itself on imaging. And what we want to see is a response in vascularity. So if on an arterial phase of a scan, tumor is taking up a lot of arterial blood, and then after a treatment, whether it be chemo, antibody therapy, radiation therapy, you see a decrease in the vascularity of the tumor, which might not correlate to a decrease in size, which happens way late. And if you use modified RECIST, you would probably see a quote-unquote higher response rate.
We do that routinely as well, and a very high percentage of patients who have so-called stable disease actually have either mild degrees of tumor shrinkage or the development of significant necrosis of dead tumor within the mass. So what used to be fully vascular actually has only a rim that's vascular, and most of it is not. So I think that that's part of the reason why the cancer is controlled for so long, and the average person is controlled for probably 40 months after a PRRT treatment, and you do see responses if you look at them in
So
different
I have
ways.
a real quick response. In the world of medical oncologists trying to understand surgical oncology, is the term grabber and pushers are out there. So neuroendocrine tumors are more likely to be pushers. That means that they're pushing against the vascular structure. Pancreatic carcinoma is more likely to grab that vascular structure. So what we see when we see these lymph nodes wrapped around the SMA or the celiac plexus or such, if we can make those lymph nodes go away, then that can potentially be translated into a more surgical resectable case. In case in point, I saw a gentleman, the patient goes for resection of the pancreatic mass, and it's found at the time of operation they could not do it because the lymph nodes were involved. So throw it to the medical oncologist, Cape Tim for a pancreatic tumor, and it all goes away. And it was like, well, that wasn't supposed to happen. So, discounting neoadjuvant therapy in some of this is a little bit premature, I think, just looking at what's vascularity and things, but size and how it's positioned up against the vessels. So from my understanding of looking at CT scans, it's really the surgeon at the time of an operation that determines whether these tumors are pushers and grabbers. You can't look at a CT scan and say that this cannot be peeled off. I'll be happy to hear them follow.
And the reason I brought that up is primarily for the audience here, because nowadays many of you, if not all of you, have access to your medical records and your scan reports. And one of the things that people will commonly come back to the office is looking at size. Oh, it went from 4.3 millimeters to 4.2 millimeters. And what we're trying to tell you here is that size isn't the only criteria that will determine response rates and resectability. So again, that's the access you have information to, but we look at things at a very different level. So don't get discouraged if you don't see a change in the size on your report.
Okay, that's important issues, and maybe the RECIST criteria will be modified in the future. Ed, we're going to talk about coming back to somatostatin analogues. There are several questions related to people who are with no evidence of disease. Do they really need to be on somatostatin analogues, or have their tumors been stable? And another question about why is it given every 4 weeks? Can it be given every 3 weeks or every 5 weeks? And another individual discussed difficulty with getting lanreotide. So can you address those?
Okay.
In 30 seconds or less?
Okay. Lanreotide, I'm not sure why people would have trouble getting lanreotide since it's FDA approved for treating neuroendocrine tumors. And if somebody's having a problem, sometimes there's an assistance program through the manufacturer, and that would be another avenue. The first two parts of the question.
If there's no evidence of disease, do you really need to be on somatostatin analogues?
Okay, if there's no evidence of disease, I think it depends on what we're talking about, no evidence of disease.
How about if you had metastatic disease and Dr. Ioannidis took it all out?
If you had 20 metastases in your liver and they were all taken out, I think that using a somatostatin analog to prevent further growth would be a very good idea. It might be worth getting a baseline gallium-68 PET so you could see what's there, because even when you think everything's out, there's probably something still there. And I think it's reasonable to suppress growth. If you don't treat, it's going to grow back. If you look at the control group on the clarinet trial that got placebo, the average time before it clinically grew significantly was 18 months. So I think it's reasonable, if you've gone through the risk and hassle of having a surgery, to consolidate your gains and just go ahead and treat with a somatostatin analog. So I think it's very reasonable to do, especially if you're not having any severe toxicity from it. On the other hand, if somebody has solitary liver metastasis that was taken out and you don't know if it'll ever come back, or it might come back in 10 or 15 years, that person doesn't really need to be on a somatostatin analog. So I think you really need to have individual discussions based on the...
Well, the fact of the matter is these metastases are not usually single, and even if you ablate 20, there's many micrometastases.
I agree.
So
I agree.
They need to be suppressed.
I agree.
All right, Joe Dillon, here's some medical questions. These are about medications. Does taking antidepressants such as Zoloft have any negative effects on neuroendocrine patients? One person mentioned they'd been on them for a long time. They've been quite effective. And another question is, what's the impact of taking antihistamines with or without decongestion severe carcinoid patients?
So the Zoloft one, and it's Zoloft is a member of the SSRI group or some variant thereof. So that's a serotonin reuptake inhibitor. Serotonin is a very important chemical within the brain for our mood issues. So, as I alluded to in the talk, there seems to be there are two enzyme systems that make serotonin. There's one enzyme system in the brain. There's one enzyme system mainly in the bowel and in the rest of the body. There are case reports for very many SSRI medications, case reports of people going on an SSRI medication and getting a carcinoid crisis or getting exacerbation of their carcinoid symptoms. That being said, probably 50% of my patients are on SSRIs. I am not sure that there's a direct linkage there, and it relates to the fact that the brain serotonin system is different to some extent than the body serotonin system. So when I counsel people about use of SSRIs to deal with depression and mood issues and anxiety issues, I get them to start slow. I get them on low dose. I get them to be very aware of any exacerbation of carcinoid type syndrome symptoms. But I think it's very reasonable to take a medication if you need a medication in the context of dealing with the stresses of having a cancer diagnosis and everything that goes along with it.
Antihistamines, decongestants?
Antihistamines, decongestants. So the antihistamines with agents that increase adrenaline levels, I would keep away from. Straightforward antihistamines. Many of the carcinoid syndrome symptoms may be related to partial histamine effects, so may have benefit. I think cyproheptadine was mentioned earlier on. So I think these agents can be helpful for some people with their carcinoid syndrome.
Okay, we're getting down to our last minute and a half, Lowell. One person asked, is there a test for MGMT deficiency? And another person asked of you about the NET test. Dr. Waltering wasn't really endorsing it yesterday. What are your thoughts on that?
So the MGMT is an immunohistochemical stain that would be done by pathologists, so it's not considered standard. It would be a research tool. We would not use MGMT staining to determine whether someone would be of a candidate. It's a hypothesis. It seemed to play out early on, but it's not a deal breaker. It's really worth the 3 months of CAPE-TIM and look and see if there's a scan change rather than to depend on some MGMT staining characteristics. The NET test I find to be really interesting. I think everyone in this area needs to look at the data and determine how best they can integrate it into their practice or validate it. I know the group at Yale that's developed it is very passionate. Can't say enough good things about what they've done. I think what we are looking for is this something that can be paid for by Medicare? And I understand that some of them will pay for it. I'm waiting to see what happens when this test is put out in a broader range of where other people get to look at it and interpret the results. And so they need to let go of it a little to let other people have experience with it to see if it's going to have staying power. Real quick, but there was an anti-CEA treatment for colorectal cancer that took years to develop. They finally got it. It's sort of like PRRT today, but it was a scanning, and it was for early detection of colon cancer. It was worthless, but it was approved, a CEA scan, and when it got out in the community and people started using it, they didn't see that it was helpful, and then the PET scan comes along and kills it. But we've got to always look at new tests with skepticism, healthy skepticism, and not poo-poo it or just because the people who are promoting are the people who have something at stake. We have to sort of look at motive for one, but also credibility and scientific data. And I think they've got the scientific data. I think it just needs to be validated and let it put in our hands, see what we can do with it.
Okay, great answer. Last question for Dave. If you typically find 35 to 40% more tumors intraoperatively than what you see on a scan, how can you find them all laparoscopically? And shouldn't you just open all the patients so you can find them all?
A good question. The surgeons who are experienced in laparoscopy, and in particular ultrasound of the liver, whether you do it open or laparoscopically, shouldn't make a difference in experienced hands. Now, if a surgeon doesn't have experience with laparoscopy or laparoscopic ultrasound of the liver versus open, then yeah, there could be a difference. That's the kindest way I could say that.
Okay, well, great. Thanks to our panelists. Big round of applause. And Bob, are we going to have lunch in here again? Okay, thanks everybody.